Hey everyone, this is Shayna Butler, and I'm working today with
Becky Gellert.
Rebecca, and we're going to present today. I'm going to take a minute and I'm going to share my screen so you can see our poster. I apologize, it might take just 1 second. All right. So I wanted to show you all that our paper is for our advanced clinical seminar. Rebecca and I worked together on this on a patient that we'll get into a little bit more detail, but I want to zoom it in so everybody can have a chance to see it. Really, when we started all this, we went through looking through everything, but I want to just give you a brief introduction of our patient. She was a 28-year-old female. She presented at CPAP for erratic behavior. She had suicidal ideation and violent outbursts. There was mood dysregulation in need of observation and medication management. We were looking to try and help her find long-term solutions that really needed to be explored with her during her time. She came in with a lot of trouble. She came in presenting a lot of different characteristics that were kind of all over the place. So when we were looking at her for a case, Rebecca and I were kind of in tandem, and then we kind of got to our executive summary part.
Okay. And like Shayna had said, this patient had presented with a lot of, mental health struggles going on at that time. It was clear she was in a little bit of a crisis situation. So it was kind of hard to kind of narrow down because there's so many things that needed to be addressed. Her safety, being number one. But, we decided after discussing it, that we really were going to try and focus on her mental health struggles. And not only her, but how an individual is facing interfere with their daily life. How does her struggles interfere with her daily life? What has got her to this point where she's being brought in by the police to CPAP? And then we kind of talked about what models and approaches, what therapeutic interventions are going to be most beneficial for her, after trying to kind of stabilize the situation. What kind of, approaches are going to will she respond to? Will it be CBT, a combination of CBT, DBT? There's a lot of trauma endured that, we'll get to in a minute, but with trauma-focused CBT, and also trying to include a use of family systems to try and get some extra support, because she was kind of, on her own in some situations. And we really wanted to help her achieve these positive outcomes. And what are going to be her biggest obstacles and diagnostic hurdles to overcome as a team? How are we going to be able to best support her, on this journey to try and get her in a safe, stable environment?
Absolutely. So at first we looked at kind of narrowing down what our objectives would be. So first and foremost, in this type of setting, especially in acute crisis, the social worker job in general is to stabilize the patient and observe what symptoms we can. On top of our assessment, that means looking at her through an observatory lens, following her for her set amount of time in the hospital, and really focusing on that assessment and what we could get from her. We wanted to establish a baseline and begin with introducing techniques to create a trusting relationship. This girl presented with very high trust level issues. Also, due to her mental health, wasn't always 100% stable in her thinking and responding to things. So that really played a huge portion of the assessment and what we were going to do. We needed to develop a treatment plan, not only for her time in CPAP, but also for discharge that includes a multidisciplinary approach, right? So we wanted to assess and address her multiple disorders and the comorbidities that went with it. She was a dual diagnosis patient, and we knew that we had to do multiple approaches for interventions in order to address and stabilize her to the best of our ability. So we, Rebecca and I talked about as social workers that we would have really come at this with the lens of encouraging the client really to accept this form of treatment and begin stabilization, which was immediate in the overall arching area of CPEP and continued care.
And because this was a patient through Shayna's, experience at her field placement at CPEP, there, neither one of us were familiar with the long-term approach that was going to be able to follow her after CPEP. So, we kind of discussed what we felt, would be appropriate treatment for her. And to deal with those comorbidities and dual diagnosis, it definitely is going to take a multi-disciplinary team to deal with those, all those things that she has going on. So obviously, we did feel that an inpatient psychiatric treatment for safety after her time in CPEP, when she was a little bit more stabilized, spending some time there to try and come up with a treatment team that was going to be able to, deal and come up with appropriate treatment measures to help her along. Definitely some pharmacological interventions for treatment of symptoms of bipolar, some possible schizoaffective disorder, some depression, all these things that she presented to CPEP with, trying to kind of one by one go through and figure out the best, medical intervention for her at that time. And involving family with a family systems approach to offer continued supports. She might be resistant to this in the beginning, but hopefully she does have some family that, according to friends, are willing to be there and support her. So hopefully to make her more successful where she hasn't been yet, to kind of get that family support and involvement more, enticed and maybe come in and do some family therapy in an inpatient setting situation. And also find supportive living arrangements for her, using some trauma-focused CBT to address her childhood trauma that she had shared. She has, some substance use disorder situations and other possible comorbidities that, we really need to kind of go through one by one, fine-tooth comb, and really find the best effective treatments for her at that time.
So absolutely. Once we, Rebecca and I talked a little bit about what our overall objectives would be treating this person and what the ultimate end goal for treatment would be. We started looking at the client through a fine-tooth comb, as we're supposed to do as a social worker, taking all the pieces of the team, both her medical team, her caregiving team, and any kind of family team that she might have listed. When she presented into the ER, she was under the influence and was, like Rebecca said, brought in under police duress. She had some serious mental health conditions at that point, and due to that, was experiencing a state of psychosis where she screamed for about, I would say, at least an hour or two after being brought in, not really truly understanding where she was or what she was doing. And we have to assess and take our time and walk through that and understand that, right? We have to get the patient into a base level of sobriety before we can actually assess them truly and talk about them. Once we got her to that place, she did allude to a lot of the trauma in her past, but really was very reluctant and non-trusting in going forward. But just knowing that the trauma was in there, Rebecca and I, really we talked about in our paper that trauma-informed approach that we would have to provide with this person-centered care, not only with the substance abuse disorder, but on top of it, these other comorbidities that we were seeing, such as the acute, psychosis, such as the depression, because once she did come down, she was sad and she was remorseful, but it didn't really change her state of being in the sense of her wanting to continue. She still presented with a lot of suicidal ideation. So the depression clearly was there. And that idea after a day of observing her that the low and the high, right? So she experienced moments of mania or it kind of extended mania, and then she would experience extreme euphoric tendencies where she would laugh or she would giggle for like minutes, like over and over and over again, not really about anything. And when asked about if she was talking to somebody or hearing something, she really wasn't. So finding these hard points of objectives of, as a social worker, what we really wanted to do and the treatment forms that we wanted to go with, it was huge for us. So and Rebecca is going to talk about this a little bit too, but in conclusion, we really wanted to develop an intense treatment plan that not only, like we said, included CBT therapy, but also this trauma-informed cognitive behavioral therapy as well. This integrated family systems approach that if we could identify through getting her some longer inpatient stay, any kind of family that was supporting her, that we could really help find her a long line of systems of support that weren't just counselors or a medical team. We also wanted to assist this young woman with understanding that she did have dual diagnosis and that triggers could begin with psychotic episodes, and helping her understand that and what those might look like. Rebecca, do you want to try and tie up the conclusion part?
Sure. So I think, tying it all together, being from when she presented into CPAP and then, with the observation and then going into a long-term treatment plan was a really good opportunity for Shannon and I to bring our ideas together and kind of, understand the dual diagnosis and comorbidities and what we're seeing and kind of as a team. And I think that happens a lot in these multidisciplinary teams as well. You have a lot of members of a team working together with their experience. So I think this was a great opportunity for us to come together with what we've been learning in this class and other classes to focus on the best course of treatment for her and what we felt was the best course of treatment. Um, and need to understand the family systems, all the underlying diagnoses that she has faced in her life. And I think that, from beginning in the paper to now, we really kind of did a really good job of tying that all together with all our studies and experience.
Yeah. Absolutely. We really leaned into the DSM-5 and really tried to pick apart each different diagnosis. We really wanted to stress to everybody that was either watching our video or reading our papers that at the end, really, we wanted to promote an understanding, right, to the patient, to the family, and any systems involved, that we as social workers had looked at through the lens of everything, and that the mental health struggles really needed support from the systems in play to help the individual really develop these appropriate coping skills that weren't necessarily in line with her substance abuse disorder. So, and understand in the process as well, her diagnosis and what it might be, and understanding that after looking at the DSM, that's going to take a little bit longer, right? So we're going to have to get this patient through her substance abuse first, get her with a clear thinking while addressing these things, but slowly work her up to a point where she not only understands the SUD, but also understands her diagnosis and what that might look for or like. So, I really do feel that in total, when we were going through the project, we worked really well together. We were able to sense of um, what we wanted to accomplish. And, we were able, I feel that we were able to give a very good clinical case study of this patient.
Yep.
So,
Totally agree, Shayna. Yeah, it was
yep.
great.
Great. So I really thank you guys for watching. If there's any questions or comments, please let us know.
All right, thanks.
Yep.